Stimulants have quietly become the elephant in the room when it comes to ADHD. Patients feel judged for asking about them, and providers feel anxious about prescribing them. So let's talk about this honestly, clinically, and with lots of compassion. ADHD is a real neurodevelopmental condition. It is not a script from Alice in Wonderland. It is not a character flaw. And it is not a shortcut to medication. Let's get that right. According to the DSM-5-TR, ADHD is a clinical diagnosis. And that means it can be diagnosed based on a thorough clinical assessment, not just testing. For children up to the age of 16, the DSM requires 6 or more symptoms present at least for 6 months and starting before age 12. Showing up in more than one setting, it could be at school and at home, both, and clearly impacting daily functioning. For adolescents, 17 and older, and for adults, the requirement is 5 symptoms, not 6. And in adults, ADHD often looks different. ADHD can show up as chronic disorganization in adults. Yes. It can also show up as poor time management, emotional dysregulation, or that constant feeling of mental restlessness. One of the biggest mistakes we make is delaying care while waiting for testing. Testing can be helpful, but it's not required to begin treatment. Waiting for weeks, months can worsen anxiety. It can worsen depression. How about work problems? Somebody can get fired at work for not meeting deadlines. And of course, affect self-esteem. I also want to address providers' fear. Prescribing stimulants responsibly does not mean being careless or the DA is going to show up at your doorstep. It means doing a solid clinical interview, understanding developmental history, reviewing the prescription monitoring programs, and following up your patients closely. We also must rule out other conditions that can look like ADHD. And some of these conditions can include anxiety, depression, trauma. How about oppositional defiant disorder? A child who doesn't want to do their work at school. We can mix that up with ADHD, intermediate explosive disorder, autism spectrum disorder, and learning disorder. So this is why careful assessment matters. Listen to your patients, pay attention to them. Culture also plays a big role. Many adults, especially women and people of color, were never evaluated as children. And it's a real thing. And we see them every day. Instead, they were labeled as lazy, difficult, or emotional. For nurse practitioners, it is essential to know your state's scope of practice laws. Some states restrict prescribing Schedule II medication, and that is a legal boundary. It is not a clinical failure. And stimulants are not the only option. Non-stimulants like atomoxetine, guanfacine, clonidine, and bupropion may also be appropriate depending on the patient. Always remember to get informed consent when you are prescribing medications off-label. To patients, I want you to hear this. Wanting to function better does not make you drug-seeking. And to clinicians, using the DSM-5-TR thoughtfully and treating ADHD responsibly is evidence-based care, not something to fear. ADHD deserves clarity. ADHD deserves compassion, and ADHD deserves confidence and not silence. Always remember, I'm Dr. Buchinwokolo, a psychiatric mental health nurse practitioner, and this content is for educational purposes only and does not replace individualized medical or legal advice. Diagnosis and treatment decision must follow DSM-5 criteria, clinical judgment, and state-specific scope of practice laws. Thank you.